This conference will now be recorded.
Then under motor system, I have covered you have to write the nutrition, power, tone, and then superficial reflexes, deep reflexes, then coordination, and finally the abnormal movements you have to write it. So I have completed the nutrition aspect, and then the muscle power, tone I have explained, and reflexes. As far as the reflexes are concerned, you have to write superficial reflexes first and then go for the deep reflexes, not vice versa. So under superficial reflexes, you can write corneal, conjunctival, palatine, abdominal, cremastic in a male, and Babinski sign. So usually all these will be absent because corneal, conjunctival usually fifth or seventh nerve you have to examine. So apparent and different, you have to take a cotton when you sharpen at one end and you touch the cornea and conjunctiva without coming into the field of vision. You have to touch and then see the blinking. And then palatine reflex, I have told already. So you have to put a tongue depressor and throw a beam of light with a torch and then touch the posterior pharyngeal wall with a kuchi. So in a positive case, you can, if it is positive means you will get the contraction of the posterior pharyngeal muscles. And the other one is abdominal reflex. So usually abdominal reflex, we have to diamond shaped around the umbilicus. So start from the periphery and come to the center. I'll show that also. So usually it is absent. Suppose if there is a hemiplegia, upper motor neuron type of lesion, on that side abdominal reflex will be lost. And the false positives can be there if the patient has underwent some surgery. So then peripheral fix will be cut, then abdominal reflex may be negative. And other thing is abdominal reflex when the patient has got a lax abdominal wall as a multipara in a female or in a male where there is a chronic distension of the abdomen. So this superficial reflex may be lost. So usually one-sided abdominal reflex lost means you have to think of a upper motor neuron type of lesion. And cremastic reflex in the male, you have to scratch on the medial aspect of the thigh and you can see the contraction of the dorsus muscle. And then Babinski sign. So this is the sign of a pyramidal tract lesion. So I'll tell you how to elicit it and what are its significance. Babinski sign is always indicative of a pyramidal tract involvement. If there are no other lesions, if there is only, if you find no other symptoms, signs are there. If you find Babinski positive, that means it is nothing but the pyramidal tract involvement. But of course, sometimes physiological. So in a child before walking, because of the myelination is not proper, so you may get a Babinski sign positive. And then the other thing, patient in deep coma or a deep sleep, or sometimes you may get a false localizing sign in case of a cerebral edema. Sometimes you may get a Babinski sign positive bilateral. But this is the important sign of a pyramidal tract lesion if the patient has got a weakness or a paralysis of the limbs. So abdomen. So you start from, so this video picture shows. So you start from periphery to center. So you are testing the segments T8 and above the umbilicus, and then at the level of umbilicus, that is T10, and below is T12. So you are examining from T8 to T12. So you have to start from periphery to center. So this is the lower abdominal reflex. At the umbilicus, you can middle, and then above you can get up from the 8th segment. So you can draw the like it, and then you see the response, contraction of the abdominal muscles you can make out. A blunt object, never a sharp object. Don't take a sharp object and make an incision over the abdominal wall. That is a crime. So always you take a blunt object and then do the, or a tongue blade. You can take you can, or a pencil, let's see, but please. So you can take and then you can apply the stimulus. Stroke the abdomen lightly on each side from outward to inward. You have to. So I told you 3 sides you have to do on both on left and right side, and then see whether the abdominal reflex is present or absent. I told you what are all the conditions where abdominal reflex is absent. And the plantar rest, this is the most important reflex. So in the examination, all the persons who got this, so they will be asked to demonstrate this sign. So always to keep the limb in an extended. Suppose the patient has got a extensor tone is increased, he cannot flex the limb, then you can keep straight the lower limb and then scratch from down to the up to the lower border of the toes. So it should not touch the base of the great toe. So in that way, you have to apply the stimulus. This also you should not use any sharp object. So you can use a blunt object like a key, you can use it, or end of the knee hammer also you can use it. So never use a sharp object, should not be used. You apply the stimulus, and the stimulus should be nociceptive. That means you have to apply in deep. Otherwise, superficially if you touch, you may not get the response. So normally normal plantar reflex is flexion of the great toe and then flexion of all other toes. So that is the positive response. And negative Babinski sign. Positive means there will be dorsal. Though you may be asked about the components of the Babinski sign also. So you may get as a short notes in your theory, and also in your clinics you are supposed to demonstrate the Babinski sign. So dorsiflexion of the great toe, and then lateral flexion of all the toes, fanning of the lateral toes, and then dorsiflexion of the ankle, and then knee flexion, and then even hip also, and contraction of the muscles. So these are the responses you will get in case of a Babinski sign positive. So normally plantar flex, all toes will be flexed. Whereas in case of a Babinski sign positive means dorsiflexion of the great toe, and then you can see the movement of the lateral four toes. There will be movement will be there, and then you can get the dorsiflexion of the ankle and flexion of the knee and hip joint. And a minimal Babinski sign. Then minimal Babinski sign also. So if the fascia, if it is contracts, that is a minimal Babinski sign. So when the patient undergoes a below knee amputation, the patient will not be having the foot. That's why you can scratch over the medial aspect of the thigh, and you can see the response of the contraction of the muscles. Then deep reflexes or the deep reflex biceps, triceps, supinator, knee jerk, ankle jerk. So you have to write in that order only. So upper limb, start in the upper limb, then go to the lower limb, and then finally the jaw jerk. So I'll show how to demonstrate the biceps. So you should know what are all the centers where the reflex is elicited also, you must know. So biceps, triceps, supinator, knee jerk, ankle jerk, and jaw jerk. So this is the patient arm should be held partially flexed at the elbow with the palm down, and thumb should be kept finger over the biceps tendon. Why you have to keep the thumb over the tendon is to be sure that it is a tendon only you are percussing. Suppose if you percuss deeply over the vessel, brachial vessels near the vessels are there, so we may be injuring the vascular injury can be there. That's why you must apply this stimulus over the tendon only, biceps tendon, and see the contraction of the biceps muscle. So in deep reflexes, whenever you are eliciting, you must expose the point, you must expose the joint, and also the muscle concerned also should be exposed. So then only you can tell whether the reflex is present or not. So you expose the biceps muscle and then see whether there is contraction is there. And the next is the flexion of the elbow, you can demonstrate. That is the biceps reflex. And the triceps, you keep your hand like this, support the hand, and then you apply the stimulus over the triceps tendon. So not over the muscle, tendon, you have to apply the stimulus and then see the extension. So observe the contraction of the triceps muscle and extension of the lower arm, you can make out. And the brachioradial, that is supinator, at the lower end of the radius, you have to apply the stimulus and then see the supination of the forearm, can be flexion and supination. So that is the response you will get when it is. So whenever you are eliciting the reflexes, you have to grade the reflexes also. I'll tell you how to grade the reflexes also. And then knee jerk, the limbs should be hanging to at the edge if the patient is conscious, another thing. Otherwise, you can just lift the limbs on support on your hands and then examine the knee jerk and then other things. So for the knee jerk, strike the patellar tendon, not over the bone. How to apply the stimulus over the tendon and then see the contraction of the, so quadriceps muscle should be exposed. So you see the contraction and then extension of the knee can make out. So you apply the pressure, the reflex the stimulus over the tendon, patella tendon, not over the patella. So this is the knee jerk. Next, this is the ankle jerk. So ankle jerk, patient should be the dorsiflexion of the foot. You should see that the foot will be extended so that the tendon is stretched. And then you apply the stimulus and see the contraction of the muscle as well as the plantar flexion at the ankle. You can make out. So dorsiflex at the foot at the ankle, strike the tendo-Achilles tendon, and then watch and feel the plantar flexion at the ankle. So these are all the reflexes. Then how to grade the reflexes? So the reflexes are usually graded. 0 means there is no reflex. And then 4 plus, very brisk. And then hyperactive with the clonus. So we'll come in a reverse. 0 means no response. 1 plus means somewhat diminished and normal, lower than normal. And then 2 plus is average, that is normal, 2 plus. 3 plus means brisk, but usually there will not be any clonus. 4 plus means there will be clonus. It is patellar clonus or ankle clonus, you can make out. So rhythmic. So if you flex and extend, suppose if you flex the knee joint and then ankle joint, and then if you apply the stimulus, rhythmic oscillations will be there. That is what is called as a clonus. So that means the reflex is exaggerated. That you can make out. If there is a patellar clonus means you have to hold the patella and then push it down and see the contraction of the muscles. So like the patellar clonus and ankle clonus, that indicate the increase in the reflexes. So that you can tell. The deep reflexes usually they will be absent in case of a LML type of lesion, and also in case of neuronal shock in the upper or a pyramidal tract lesion, upper motor neuron type of lesion. In the neuronal shock, these reflexes will be absent or minimal, and in case of a lower motor neuron type of lesion, these will be absent or minimal. So in case of upper motor neuron lesion, usually the reflexes will be brisk or increased. Now comes the other things, coordination in the upper limb, Fingernail Test. So the outstretched hand you have to keep, and then you ask the patient to touch the tip of the nose. So with open eyes and closed eyes, both hands you have to test it. So that is the coordination in the upper limbs. So usually this will be lost in case of cerebral or when there is a muscle power, when there is even 0 or 1 cannot elicit it. And usually in coordination is the sign of cerebral disease commonly, or when the muscle power is very poor also they may not be able to demonstrate. Similarly in the lower limb, you have to test coordination by heel-knee test. You have to test. So you ask the patient to keep the heel over near the knee joint and then ask him to move downward. And then he should do rapidly like that. So this is the heel-knee test. So in the upper limb, Fingernail test, and in the lower limb, heel-knee test has to be done to show whether the patient has got any incoordination in auto examination. Then the sensory function. So after the motor system, so any abnormal movements, common abnormal movements you will get is the tremor one, and then chorea, and the other things are the hemibalismus are there. So usually tremor means whether it is a tremor intention, another thing is intention tremor, that is another thing. So usually point tremor or force tremor, and then resting tremor. So usually resting tremor indicates there is a Parkinson's, the extrapyramidal system involvement. The patient can have the resting tremor. You have action tremor. Usually you have to think a point tremor. Usually you can get in case of thyrotoxicosis, or even sometimes professionally, or alcoholics, anxiety, neurosis. In all these conditions, patient drug induced. So usually the drugs used in bronchial asthma, beta agonists. So this can also produce the tremor. So tremors, whether the patient has got tremor or is it a hemibalismus, one-sided violent movements on one half of the body, that is hemibalismus. This is also a sign of a extrapyramidal system involvement. And then other things with chorea, usually caudate nucleus involvement, patient can have chorea, acetosis, chorea, these are all abnormal ones. If the patient has got those things, we have to mention it. Next, coming to the assessment, sensory. Sensory assessment, you have to use for a touch, temperature, touch, pain, and temperature, and posterior columns also you have to test it. So light touch, so usually you can take a cotton wool and then touch it. So you have to tell him every time, you should not ask whether you are able to make out the, say you are feeling the sensation of cotton wool or not. So just you ask the patient to close the eye and then touch. So usually symmetrically you have to test simultaneously. It's not simultaneous. So one side you have tested on the forehead, see forehead. So both sides, identical sides, you have to select and then you touch it. If he is able to feel the sensation, he has to tell one like that, one, or I am feeling like that, he has to tell. So like that, corresponding areas should be tested like that. So you should not ask every time, are you feeling the cotton wool sensation? Similarly, pain also, same thing. You should not ask every time, are you feeling, are you feeling? Is there so one thing you have to ask in the pain, so whether the intensity of the pain is equal on both sides, or is there any decrease on one side? So if there is a touch is decreased and pain decreased, so usually you have to think in terms of a peripheral nerve involvement. And then other thing, suppose pressure usually that is a posterior column test. You can measure where the patient is feeling as if some constricting band over the muscles. So that is a typical symptom they can have in case of a posterior column. And next one is the cortical sensations. This is stereognosis. That means you give some object, so known object, usually the coin you give, pen you can give, and then ask the patient, close his eyes and then keep it over the hands and then let him recognize what is festival. So, or you can write even some figure also you can write and then whether he is able to make out or not. But one thing you have to remember is in stereognosis, so there should not be any loss of touch. So usually if there is a peripheral nerve lesion is there, so cortical sensations cannot be appreciated. And tactile localization and 2-point discrimination. This is also a cortical sensation. Tactile localization means he has to point out exactly where you have touched it. So that is tactile localization. And you take a compass and then 2-point discrimination, whether he is able to make it as a single point or as he is appreciating 2 points like that. So that is 2-point discrimination. So this distance will vary usually in the lower limb because of thick skin. So the distance will be more. So that you should take it normal only. And whereas in over the face and lips, the distance will be decreasing. The sensitivity will be more in the skin. So that's why the tactile localization and 2-point discrimination you have to do under cortical sensation. Other thing I told you, graphesthesia. You can write one number and then whether he is able to recognize that number or not. Graphesthesia. These are all the sensory function. So sensory system, I told you, touch, pain, temperature. Temperature also usually you can take a tuning fork. You can dip it in a cold water or a hot water. Hot water that should not exceed more than 23, maximum is 30. Beyond that, it should not increase because it will cause the burns. That's why you don't use hot boiling water. So for that, you can use the temperature and then see whether he is able to make out the temperature normally or not. So hot and cold you can test. Touch, pain, temperature, and pressure. I told you pressure. Usually this is lost in case of a posterior column or dorsal column involvement. So joints, so whether you keep it one particular position and whether he is able to appreciate or a pressure sensor is able to make out it. Cortical sensations already I told you. tactile localization, tactile discrimination, stereognosis you can ask. So how to touch the light touch? So you can take the cotton list like that, and then corresponding areas you can tell, and then he has to tell 1 1 1 like that. Yes, if he is noting. Or if the pain you are taking a not the you should not take needle, some stick like thing, some small pointed one, and then you can ask whether he is able to appreciate the pain sense both sides equally or not. Is there any difference from one place to other? Like that, you can examine for the touch and pain temperature. So this is for the ability to dullness, whether he is able to appreciate is it sharp or dull. So that indicates if there is a peripheral neuritis, a neuropathy. So this will be lost usually. Or there may be sensation will be felt less. And cortical sensation, I told you already, you write one figure and then ask him to tell what is that like. So coin test. This is stereognosis. You ask the patient to keep, you ask the patient to close the eye and then keep a coin or a pencil or pen, and then whether the patient is able to appreciate that or not, you can work out. And after that, so sensory motor system, sensory system. Now you go for the, you have to, for completion sake, you have to write the cerebellar signs, signs of meningeal irritation, skull, spine, you have to mention it. So cerebellar signs and autonomic nervous system also we have to mention it briefly. So what are the cerebellar signs? Speech, scanned speech, that is a drunken speech. The syllables will be split, scanned speech or a drunken speech. So that is the speech disturbance they can have. And nystagmus. So nystagmus, he may not be able to tell, but the patient's attendants may tell. Or if you are watching him, you can make out the oscillatory movements, you can make out whether it is a horizontal or vertical or rotatory nystagmus. You can make out usually the rotatory movements you can get in case of a extrapyramidal disease or some poisoning, you can get it. And then horizontal nystagmus, usually you can get in muscle paralysis or a cerebellar sign. So on the side of the lesion, you may find a nystagmus, you can oscillatory movements, you can get it. But usually if you keep at the periphery for the extreme, then you may, sometimes they may have, but if it's not considered, that is an abnormal movement. So nystagmus, horizontal, vertical, or is it a rotatory nystagmus? You have to make out. A titubation. So titubation means of the movements of the head and neck. So usually that is one of the sign of the extrapyramidal. Usually in case of Parkinsonism, you may get titubation. And dysmetria, that means dysmetria that you can make out. So finger nose test. So if you ask the patient to touch the nose or finger to finger test, so at the reaching of the point, they may have some abnormality. So that is the movement. There may be some oscillatory movements can be there. They have some difficulty in touching the object. That is what is called dysmetria. And dyssynergia means where there is incoordination is there. That is dyssynergia. And then hypotonia. That is one of the feature of a cerebellar sign. Hypotonia can occur in case of a lower motor neuron type of lesion and cerebellar lesions, and also in case of neuronal shock in the upper motor neuron type of lesion. And the other thing is the ataxic gait. They can have the ataxic gait. That is, they will have really one side they may fall. So that is ataxic gait they can have with open and as well as closed eyes. Both. So with open eyes itself they can have in case of a cerebellar lesion. Whereas in case of posterior column, so they can stand normally. Suppose if they close its eyes, then the swaying will be increased. So when the swaying increases during while closure of the eye or in the night time, so that is a sign of a posterior column lesion. So that we call it as a rhombus test. I'll show, I'm having the slide. So whether, and the other thing is ataxic gait, you ask the patient to walk on a straight line and then see whether the patient is swaying to one side or other. Usually cerebellar lesion, on the side of the lesion, the patient will have swaying. So finger nose test. So outstretched finger, and then he has to touch with the nose with the index finger. So like that, he has to repeat from on both the limbs, right side and left side, and then see whether they is able to appreciate the he is able to break up the breakage of the movements or is having difficulty touching the point. So this is mainly for the in coordination, or in case of cerebral disease, you can make out finger nose test. You can make. And another important thing in case of a cerebral disease is alternate movements of the palm. So for alternate flexion and rapidly, it is in case of a cerebral disease. So the patient cannot do the alternate movements rapidly. Rapid alternating movements will be lost interest because of incoordination in case of a cerebral disease. Now this is the Romberg's test. So this Romberg's test is important to differentiate, is it a cerebellar disease or is it due to the posterior column involvement? So what is that you have to do is ask the patient to remain still. So feet together, and then for 20 seconds, ask to close the eyes and then stand. So usually in a normal people, so after if you ask him to more than 1 minute, then that is a false sign. So 20 seconds you ask him and then you see the swaying. So and then ask the patient to open the eyes and then see whether the patient sways with open eyes. So that means it is a cerebral disease. So that is because of the hypotonia and muscle weakness. So the patient will have this swaying. Whereas in case of posterior column, so usually when the eyes are open, when the vision is perfect, he will not have any swaying. So once the patient closes the eye, then there will be swaying. That is in the indicative of a posterior column involvement. So Romberg's test positive means there is an involvement of the posterior column. Cerebellar involvement in both open eyes or closed eyes, patient will have the swaying. So that is what is called Romberg's test. So posterior column, what are the tests? So I told you cerebellar, what are all the things you have to see? I put one more thing, that is a knee jerk, pendular knee jerk will be there. Hypotonia, pendular knee jerk will be there, and then incoordination, and then patient dysdeudoconia, and then patient will not be able to see the rapid movement, and rebound phenomena can be there. So these are all the signs of cerebellar. Romberg's test, so usually positive indicates that is a posterior column involvement. So what are the things we have to examine for the posterior column? So pyramidal tract is over, cerebellar signs, sensory system, then peripheral nerve and later. So then cerebellar signs, posterior column signs. What are all the signs you have to test? Vibration. So usually the vibration, you have to use the tuning fork 128. You have to use that one, and then you have to keep over the bony prominence, and then see whether the patient is able to feel the vibrations, not the sensation. So vibration, is able to feel the going and that you should ask. Vibration, is he feeling or not? So if he is absent, that is a sign of the posterior column involvement. So we have to keep the tuning fork over the bony prominences over the frontal middle of the forearm, and then over the olecranon process, and then patellar, like that. You have to keep over the bony prominence and compare on both sides and see whether the vibration sense is present or absent. So usually the loss of vibration sense is called the parallesthesia. Even over the manubrium sternum also you can keep, and then you see feeling the vibration on both sides or not, you can test it. So 128 frequency you have to use it. And another thing is a joint sense. So joint sense means you can test any joint, so provided the joint should be fixed, and then the movement should be flexion and extension that should not exceed more than 10 degrees. So this with open eyes, first we have to teach the patient. So whether if you are examining in the lower limb, so you can choose the great toe and then fix it and then flex it and show this is a flexion, and if you extend it, that is extension and neutral position. So like that in the upper limb, you can take with thumb or any finger you can take and then test it. The movement the joint should be fixed, because if it is not fixed, even skin stretching can tell the position of the limb. That's why. So you fix the joint and you hold the finger or the toe and then flex and extend it, whether it is flexed or in the middle position or extended, you have to tell. So usually the joint sense will be lost in case of the posterior column. So vibration and joint sense both will be lost in case of a posterior column, and earliest is the vibration sense and the late is the joint sense. So another thing is you keep one joint in one particular position, one limb, and then you ask the patient to keep the other limb in the same position. That also you can test it for the joint sense. So one is fixing of the joint and then asking him to locate whether it is flexed or extended. Or another thing is you keep one joint flexion and then you ask the patient to keep the other limb in also in the same position. So these are the tests you can do for the posterior column. So usually posterior columns are lost in case of a syphilis, that is tabes dorsalis, where the posterior columns are involved. Or the posterior columns can be involved in nutritional disorders, say in B12 deficiency. So nutritional causes, or in case of commonest vitamin deficiency, so B12 deficiency, the posterior columns can be affected. Or in case of spinal cord compression is there, so below the compression, the compression is complete, then pyramidal tracts, extrapyramidal, posterior column, that is all can be affected. So these are all the conditions where the posterior column can be affected. Next, peripheral nerve examination. Peripheral nerve examination means you must palpate the peripheral nerve. So usually ulnar nerve at the elbow joint, you can test it. And then in the popliteal nerve or any peripheral nerve, just is there any thickening of the nerve present or not. And then whether he is able to feel the sensations or not, whether there are any abscesses or a nerve, you can make out irregularity in the surface, you can make out. And then on that particular segment, you have to test for the touch, pain, and temperature, you can test it. So this is for the peripheral nerve examination. Usually the common causes for the peripheral involvement are the infective polyneuritis, and then tropical disease, diabetes, and then tropical diseases like leprosy, and sometimes toxins. These are all the alcohol. There are so many things which can affect the peripheral nerve. So this is, so you must feel the palpate the nerves, and then whether there is any tenderness present, inflammation present, or any swellings are present, you have to test. And then along the distribution of the nerve, peripheral nerve, you have to test for the touch and pain, you have to test it. And already I told you cerebral signs you have to examine, and then signs of meningeal irritation. So that is in the neck, you have to flex the neck, and usually the patient will have pain will be extended, and if you flex the neck, patient will have severe pain. So that is the pain they can have in the neck. Or the other things is the Kernick sign. Kernick sign means so you must keep the patient in a supine position, and then you flex the knee and hip, and then try to extend the knee joint. So then patient will pain in the back. So that is stretching of the nerves. So that can produce the pain. So Kernick's sign can be there, or meningeal irritation in the neck rigidity, Kernick sign, and then Brudzinski sign. Brudzinski sign, usually this is elicited in children commonly than in the adults. So neck sign and leg sign. Suppose if you flex the neck, the legs are also will be flexed. So that is the Brudzinski neck sign. A leg sign means if you flex one leg, the other leg also will be flexed. So these are the three signs which are elicited as a meningeal irritation of the meningeal. So meningeal irritation signs doesn't mean it is only the inflammation of the meningitis. So once it is there, you should not think the patient is having meningitis. So in case of in elderly individuals, if there is no history of fever, vomiting, headache, not like that, and he is having a neck stiffness, you have to rule out the cervical spondylosis, or any trauma is there, cervical spondylosis. You have to think of it. So like that, in case of elder, another is in case of a CVM, in case of subarachnoid hemorrhage also. So patient may have neck stiffness. So these are all the things we have to rule out before telling that the patient has got a meningitis. So, you have to look for the neck sign, you have to look for it. Then you have to look for the Kernick sign and Brudzinski's neck sign, and then leg sign you have to examine it. Then bowel and bladder, is there any disturbance of the bowel and bladder? Is there any retention? or incontinence is there. So, sometimes the patient may have bladder. There are various types of bladder abnormalities are there. So, usually precipitancy, hesitancy means he will go for the washroom and he will not. He will have the urinary sensation, but he cannot pass urine. That is hesitancy. Precipitancy means before going to the washroom itself, you will have the situation. That is precipitancy, hesitancy, precipitancy, retention. So usually in case of a sympathetic nerve involvement, so patient can have retention, or when there is a higher cerebral hemisphere lesion is there, so then also patient may have retention of the bladder. So incontinence, that also can be there in case of a higher center involvement or a parasympathetic involvement. Patient can have incontinence or any local pathology also. So whether the patient has got all these, any bladder disturbances are there, you can make out it. So neurogenic bladder, so where he will not have control over the bladder, that is neurogenic bladder. So this can also be a neurological manifestation in the terminal stage of diabetes, or in case of spinal cord compression. The patient can have the involvement of bowel and bladder. And last, you have to feel for the skull and spine. So what for the skull? So usually, if the patient gives history of trauma, road traffic accident or fall from a height is there, so then you have to palpate the skull and then see whether there is any depression, fracture, depressive fractures are there. You can make out. Or sometimes patient might have forgotten the injury. So he may come with a neurological deficit after a few months or years. Then if you palpate the skull, you may find the depressed fracture or mental changes are there. So you can attribute to the injury like that. Or if there are any tumors are there, secondaries may be there in the skull. So you may be able to palpate the swellings in the skull, what the subcutaneous tissue like that. You can be able to, or aneurysm is there. There may be pulsatile masses can be there. So these are all the things you will feel in the skull. Shape of the skull also is important. Certain shapes, abnormal shapes, oxycephaly, triancephaly like that, they may have some neurological deficit. So any abnormality and then palpation you can see, and then any pulsations, aneurysm, bruising, you are able to feel, or any secondaries are there, you can see in the skull. And spine, of course, whether there is any deformity of the spine is there. Tenderness is the deformity, usually gibbous deformity. So that may be there in tuberculosis or a congenital sometimes. So any abnormality of the spine is there. And then usually the muscle lattice muscle on either side spasm indicates there is some pathology in the spine, lordosis. So any abnormal or spine over the dimple, you may find it, or tuft of hair. So can be there. So that indicates that there may be neurological, underlying neurological deficit can be there. So is there any skull or spine deformity is there? So you have to look for it in the especially when the patient comes with a paraplegia. You have to look for all this, and any disc prolapse is there. So like this you can make out in this. And then other system, that is compulsory. You have to examine the other systems, especially CVS. So to know whether the patient has got any cardiovascular, especially thromboembolic mitral stenosis, or any valvular disease which has produced the thromboembolic phenomena, or myocardial infarction, or even cardiomyopathy. So you have to examine the cardiovascular system to show any evidence of the thromboembolic phenomena. And the respiratory system, usually whether there is any malignancy, or secondaries may be in the neurological system, or in case of a tuberculosis, a neurotuberculosis, so in that you may find a pulmonary tuberculosis membrane. Second after that he may develop a tuberculoma like that and having a neurological deficit. So that is, and similarly the GIT also. So GIT primary may be in the abdomen, and then the hepatic or any other thing, and then secondaries may be in the brain, breast, everything. You have to examine other systems, whether the patient, so all these systems, other systems you have to mention and see whether all are normal or anything abnormal. You have to search for it. So these are also, the CNS is very, very important. So you have to write in the order only. You should not write your own findings or your own order. So you must see the order should be maintained, And then whatever test you are doing, because the neurological system is represented bilaterally. So that's why whatever test you do it, you write it, and then left and right you have to mention it. And finally, you have to write the diagnosis. So when you are writing, usually the commonly you get in the examination is a cerebrovascular accident. So in that you have to mention your diagnosis, not simply hemiplegia. So you have to write first is the CV, cerebrovascular accident. Next comes where is the weakness or hemiplegia, is the right side or left side. So you have to mention the side. CVA, right-sided hemiplegia. Then where is the lesion? In the brain. So usually in the internal capsule will produce. There are other sites are there which can produce hemiplegia. So commonly the classical hemiplegia, that means involvement of the pyramidal tract and also the facial nerve, upper motor neuron type of facial nerve, palsy, same side. So that is a classical hemiplegia, usually occurs in case of the internal capsular lesion. Suppose if there is a right side hemiplegia, the lesion is on the left. So left internal capsule you have to write. So you need not mention, so where exactly anterior or the middle or posterior. So you can mention just internal capsular lesion on the left side. Then the artery supplies, usually which artery supplies means it is the middle cerebral artery, lenticular striate branch of the middle cerebral artery. So that is one thing you have to tell. And then finally, what could be the pathological lesion which has produced? So is it a thrombosis or a hemorrhage or embolism? You have to mention. So by asking the history and other things, you can come to a conclusion whether it is a thrombosis or a hemorrhage or embolism. So usually embolism means you have to look for a cardiovascular disease, valvular disease, or myocardial infarction. You have to look for it. And then for the thrombosis, it could be simply atherosclerosis can be there, or any other source for this thing thrombosis. You have to look for it. So is it thrombosis or hemorrhage? Hemorrhage means atherosclerotic plaque and rupture, or is it due to hypertension can be there. So which can, or an aneurysm which can bleed, which can produce a hemorrhagic stroke. And finally, so what could be the precipitating factor etiological? Usually, is it atherosclerosis or is it due to any other pathology which has produced this one? So finally, you have to write in case of a neurological disease, commonly in case of a hemiplegia, you have to write cerebrovascular accident, and then right-sided or left-side hemiplegia, and internal capsular lesion you have to mention, and the artery which supplies, usually lenticular striate branch of the middle cerebral artery, and pathological lesion you have to mention whether it is a thrombosis, hemorrhage, or the embolism. And then what is the etiological factor? Usually is it due to atherosclerosis, or is it due to hypertension or diabetes and hypertension? So like this we have to mention. That is the full-fledged diagnosis for the cerebrovascular accident. So in that way you have to write the examination of the neurological system. In that order you have to write. So I have completed the examination of neurological system. In the next class, I would like to tell about the examination of gastrointestinal system. So if there is any doubt, so you can present, I can clarify your doubt. Okay, thank you.
Ma'am, excuse me, ma'am.
Hello? Yes.
Ma'am, what's the syllabus for the first internal exam, ma'am?
First internal, I don't know, whatever system is covered, that will be included. And you will have the MCQs also. First internal assessment, the system they have covered will be systems starting from your fourth semester, fourth, fifth, sixth semester, and then eighth semester, whatever topics covered, that will be
Ma'am,
kept.
actually, we aren't sure what is covered, ma'am, because this has been going on from second semester, third semester onward. So, like, there is confusion as to which topics are covered. Ma'am, if any
It
syllabus
will
could
be
be
the
given to us.
tropical diseases, infectious diseases, nutrition, is it not? Whether cardiovascular and other systems, whether they have started or not, I don't know. So these are the systems. Immunology, I think they have covered it. Rheumatology, I don't know. So whatever system, hematology, is it started for you or not? Hematology
Yes,
over or
ma'am.
not?
Ma'am, started.
Over. So whatever system has started, that will be covered, and you will have the for 60 marks you will have that, and then in that 12 marks for your MCQs. So only the covered portions will be kept. 12 internal, 12 for the MCQs and 48 for the essay question and other things. So totally 60 marks. Okay.
Ma'am, exam will be
Yes.
online, so ma'am, essay questions we'll have to write online.
Online, I don't know whether you cannot come. No, I don't know how. If there are online means you will be given only MCQs. I think you can't do we can't do essay questions. Is
Okay,
it
ma'am.
not?
Thank you,
Suppose
ma'am.
for examination purpose, exam going to tell, then we ask them to come here and then we give essay questions just like the pattern of a university model. But here I don't know. Next month only you are having, no?
Yes, ma'am,
You are
ending
Yes,
having
ma'am.
August.
probably if it is only the next month means usually the MCQs may be there. I don't know exactly. So if there is anything, I'll tell you in the next class. I'll tell you. Okay. Thank you.
Ma'am, dermatology and psychiatric questions will be also there, ma'am, for first internal.
Whatever portion covered in dermatology, psychiatry, only MCQs, I think. I don't know. MCQs you may get. Because you cannot come, you have to come by August, I think. You have to join, but whether they allow it or not, I don't know. So you are supposed to join by August 1st, I think, August 2nd or 1st. But will you be able to come or not, I don't know.
Okay,
So
ma'am.
it is in fluid level only. Okay. Read well at home. Thank you.
Okay, ma'am. Thank you, ma'am.
Thank you, ma'am.
Yes, yes.